Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Dr Liz Dapré, an academic GP and co-chair of the organisation GPs Championing Perinatal Care. Liz joins me to discuss the vital but often overlooked role of primary care in maternal and perinatal health, and how her organisation is working to ensure the voice of general practice is heard by national policymakers and what it does to support GPs in practice. In this conversation, we discuss the key problems in perinatal care across the NHS and what needs to happen to address some of these issues. Liz also talks about health inequalities in maternal health and the role GPs can play in tackling these, and provides practical advice on delivering high-quality 6 to 8 week postnatal checks and why this should be seen as a holistic review of a woman's transition to parenthood rather than just a series of clinical boxes to tick. We also discuss how GPs can better identify and support women following birth trauma, as well as managing gestational diabetes and the ongoing risks for women affected by this. I'm really pleased to welcome onto the podcast now Dr Liz Dapré, an academic GP and co-chair of an organisation called GPCPC, which stands for GPs Championing Perinatal Care, and which advocates for the role of primary care in perinatal care. Liz's research focuses on developing better interventions to modify risk factors in high-risk pregnancy, with an emphasis on diabetes, cardiometabolic medicine, and reducing health inequalities. And she's here today to talk about maternal and perinatal care and the role of primary care. Thank you so much for coming on the podcast, Liz.
Thank you for having me. It's very exciting to be here.
So I mentioned at the start, you're the co-chair of GPCPC. Can you explain a little bit about what that organisation is and what it is you're trying to do?
So GPCPC was set up in 2021 by two GPs, Dr Judy Shakespeare, Dr Annie Jacobs, and they really recognised that perinatal care in general was just not being delivered as effectively and compassionately as it should be or could be. So they set up this network of GPs all over the UK to try and champion the cause to improve the way that we deliver perinatal care in primary care, with a specific kind of focus on sharing quality improvement, sharing best practice nationally, and also acting as a bit of an advisory body for things like policy changes, guidelines, and all that kind of thing too.
And how is it that you became interested in this particular area in perinatal care?
I think a little bit of personal experience and also professional experience. So, unfortunately, I was one of the many women who've experienced a traumatic labour. And I think then in my professional practice as well, I worked in a variety of different specialties from A&E through to obs and gynae through to general practice. And in each of those touch points, I witnessed women who had really traumatic experiences and then both again professionally and personally experienced that fragmentation of perinatal care and felt very passionately that we could be doing better. And that's kind of how I've ended up championing the cause for perinatal health.
In the olden days, as it were, GPs were obviously really core to maternal care, but they're often really not mentioned when it comes to maternal and perinatal policy, despite them playing such a big role. Why do you think primary care is frequently left out of these conversations, and how are you working to ensure the GP's voice is heard?
This is a massive question and one that we've been discussing within GPCPC as well. And if we look back at the history of maternity care and maternity provision, historically GPs had a far more active role in even delivering babies. I think Dr. Judy
Yes.
Shakespeare talks about GP-led obstetric units. So we used to have a far more hands-on approach to managing women and a lot of shared care between maternity services and primary care. And then it shifted towards more of a focus on continuity of care within midwifery, which again is quite right. And that continuity of care is so important for women. But in doing so, we've shifted the care of women predominantly into maternity services. And so that has now led us to developing a primary care workforce that is less hands-on, less experienced in managing women throughout perinatal period specifically. We've become de-skilled. It's also an issue when you think about the way that we measure maternal outcomes. So because it's more hospital-led, secondary care-led, we now focus a lot on hospital metrics as our key performance indicators for how we're doing in delivering maternity care. Whereas actually we know that the perinatal period is far more complex than that. And we need to look far more widely at more metrics and how women are doing outside of that hospital touch point. So, in terms of what we're doing in GPCPC to try and improve the primary care voice within perinatal care, we're working with policymakers. So we have some NHS England working groups. We advise on some of their policies that come out. We work with other advisory bodies. So we partner with Make Birth Better, Maternal Mental Health Alliance. We do a lot of work with MASIC, the Birth Injuries organization. We partner with One Voice. We do work with Tommy's. So we're trying to get our voice out there a bit more as a unified and amplified voice about the importance of GP's role in perinatal care. And hopefully, slowly, we're championing the cause for GP's involvement. Think about the bigger picture here as well. If we look at the way that leadership is delivered in the NHS in general, it's a very top-down model of leadership. So we have lots of NHS England down to secondary care and then down to primary care. So the GP voice is often almost a secondary thought sometimes in some of these policies. And I don't think that we necessarily recognise and appreciate the role of GPs adequately within perinatal care. And I think that's something that we need to change. And that's part of what GPCPC is doing at the moment in terms of trying to just amplify the primary care voice so that we have more of a voice and our role is recognised more within policy.
What are some of the key problems in perinatal care more widely at the moment?
This is a really, really difficult area at the moment,
Mm.
isn't it? We have inquiry after inquiry highlighting all of the issues in perinatal care. We know that women are really angry at the state of perinatal services, maternity services. We know that we have really poor outcomes. We know that maternal deaths are increasing, which to me is just mind blowing when we're having increasing maternal deaths despite these ongoing inquiries. And so, if we try and break it down to really get to the crux of what the issues are, I think there's leadership, firstly. We need some really, really good leadership in the perinatal space. The government talks about maternity commissioners, which I think would be great. And I know that there's loads of people who are championing that all over social media at the moment, which I think is really important. We need to standardize care in maternity services. We need to improve continuity of care. And through that, I mean communication between the services involved in perinatal services. And we also need to improve communication with women. We know that's something that comes out so commonly that women just don't feel that they've been communicated with effectively. We need funding and capacity. I think that's probably the message from all of the NHS at the moment is that we just have a lack of capacity. And I've worked in obs and gynae units, and staff are trying as hard as they can to provide this care. Everyone's so squeezed for time at the moment, and I think that's really an issue. And then again, with the kind of health inequalities angle, we need to get so much better at really recognizing and addressing health inequalities. I don't think just saying we're going to introduce mandatory cultural competency training is enough. I think we need to get much better at really training and equipping staff to have active bystander training, how to actually challenge people and how to challenge situations when they feel that something is not good enough, and how do we work collaboratively to create a real culture of psychological safety where people, staff and patients, feel comfortable to speak up when things aren't right. And I think a lot of that will happen in conjunction and collaboration with organizations like One Voice, where we really need to be doing this work from the ground up. We cannot implement maternity strategy or perinatal strategy without the patient voice and the public voice. It cannot be an add-on at the end of a strategy. It has to be there at the very foundation of development of that strategy if we are to make sure we're tackling health inequalities properly.
They are pretty staggering, some of the figures, and when it comes to inequalities, and that Black and Asian women face significantly higher risk of maternal mortality. Where is the system failing these women?
I mean, that's going to be the really interesting output from the Ockenden report, isn't it? Which I think is due later on this year. I mean, it's such a big problem from the tools that we use to the language that we use to not listening appropriately and acting on patient concerns. The whole way that we deliver care for women needs to be improved. I feel quite strongly that we don't listen properly and we don't learn from what people are telling us. I think there's certainly a culture of reactivity and defensiveness where lots of people are given these outcomes and shown stark inequalities. And there's a real sense of, oh, but that's not me. And I didn't do that. And we don't do that here. And I think then that feeds into an even wider problem of a lack of diversity within leadership positions in the NHS. Because if you have a leadership board that is made up of middle aged white men, they may well understand, but they may not even be aware of some of the issues that they're missing within provision of care to specific groups of women. And that's why I feel so strongly that we need to improve the diversity of our leadership. We need to really improve the patient and public voice within the foundation of strategy development if we are truly going to start to make any change in health inequalities.
I was going to talk to you about health inequalities. Is there anything that general practice and GPs can do, or any role they should be playing to help address those inequalities?
Absolutely. I think everybody has a massive part to play here, from the basics of accessibility, so availability of interpreters long enough for an appointment that facilitates that interpreter engagement, to more proactively seeking out patients who find themselves marginalized from the bulk of society within the UK. There's so much that we can do to try and address those health inequalities. One of my colleagues, Dr Divya Tharan, she's done an incredible quality improvement project in Salford, where she's looked at equity and access to the postnatal check, for example, and she's changed the way that the GP practice actually offers the postnatal check. And it's a really great piece of work. And it's, I'm sure she won't mind me saying it, it's not rocket science. This is very implementable and scalable strategy that she's implemented within her practice. And she's found that it has increased engagement and improved equity of access to the postnatal check. So there's so many different things that we can do in primary care. And I think one of the most important things is that we need to educate ourselves as primary care clinicians to be more aware of those stark disparities and to be aware of the specific perinatal health problems that may disproportionately affect different groups of women, and then be a little bit more curious in our consultations and ask the right questions just to make sure we're not missing anything.
You mentioned the 6 to 8 week postnatal check there. That's a pretty critical touch point where GPs have contact with mothers and their babies. In your view, what does a really effective postnatal consultation look like, especially, given the pressures and constraints on GPs in terms of resources at the moment?
I would love to have my own postnatal clinic where I get an hour for every woman who comes in and we can really talk through everything and kind of break everything down. The NHS England postnatal toolkit has recently been published in January, which I think is actually quite good at breaking down all of the different things that we should be tackling within the postnatal check. But the reality is, even that document will probably take about 2 hours to read. So the amount of work that we're expected to do in a very compassionate way within a 10-minute consultation is just unfeasible. And I think we need to really rethink the way that we deliver postnatal care. I've worked in different places. Some places offer 10-minute consultations for women, some places offer 30 minutes, some places offer no postnatal check, which I think is a really key point to highlight, is that GPs are contractually required to provide a standalone postnatal check. So if there's any GP practice that is not doing that, please, please go back, have a look at the contract and rethink your postnatal delivery. One of the key things is really looking at, firstly, how the woman's doing. Historically, the NHS has focused very much on contraception, pelvic floor, all the kind of tick box things. And postnatal care is not a tick box exercise. It's something that is incredibly personal. And I don't think we recognize and appreciate that fundamental shift from not being a parent to suddenly becoming a parent, that whole, what we refer to as the matrescence period, that I never even understood that until I became a mother myself. And that shift psychologically, physically, career-wise is such an incredible transition, and we really need to appreciate that more in our consultations. So I always focus very much first on how is the woman doing? How are you? How was the birth? Did it go how you wanted it to go? Was it terribly traumatic? What are we dealing with here? And then it may be that we use that consultation to purely focus on mental health side of things, and that's absolutely fine. And then I'll bring you back and we'll go through the other stuff. I don't think that it's effective if we just try and shoehorn absolutely everything within that consultation, because we know that women don't feel listened to during those consultations. We know that often the GP's agenda does not match up with the woman's agenda in those consultations. And so I think it's really, really important to just take a couple of minutes to agenda set within that postnatal appointment first. And then if it means that you have to bring those women back to talk more about the other things, book them in for a contraceptive review, absolutely fine, then we can do. But I think we need to move away from seeing the postnatal check as a tick box exercise and trying to really treat women more holistically and understand what's gone on around their birth period.
That's such good advice. Also, there's a lot of expectation on women. I think that's still the case now, that you're supposed to just be really happy because you've got this baby that you've been growing for 9 months and hooray, here it is. And it's not always like that.
Absolutely. Yeah. I think as a doctor who had an interest in women's health, who was incredibly independent, and then suddenly I didn't feel that overwhelming sense of joy because I was still in shock from this traumatic experience and I struggled with feeding. And it really hit me like a ton of bricks. And I felt that I was failing as a mother, as a woman, because I wasn't able to do all these things that everybody kind of told me that I should be able to do very naturally. And that was the same for colleagues as well. And I think feeding, particularly, is a really emotive and difficult area, because if you cannot breastfeed and your colleagues are telling you that actually you have to breastfeed because that's the best thing for your baby, that can really pile on that guilt as well. And I know that some of my colleagues are doing some specific and really, really important work around breastfeeding guilt and feeding guilt, which will be really interesting to see what they find. But all of these kind of nuanced discussions, people don't necessarily appreciate until you've been through it, or you've had a friend or colleague who's been through it, and suddenly you think, "Oh, actually, it's not just about contraception and sending you the squeezy app. There's so much more to this than that." And I think, we haven't even touched on women who experience loss and pregnancy loss and stillbirth. And for those women, I can't even imagine how difficult it must be to navigate the postnatal period, particularly having to remain on the postnatal ward in a lot of cases with women who've delivered healthy babies. And it's really difficult to provide care for women when we're trying to shoehorn everything within a 10-minute consult, when we don't have up-to-date discharge summaries. All we see on the system is that a woman has been discharged from the postnatal unit. It's so, so critically important that we really join up the dots between perinatal services so that we can truly provide that more holistic and compassionate care to women.
There was a recent parliamentary inquiry, and you've talked a little bit about this, into birth trauma, and it painted a really bleak picture of the care that women were receiving, lack of compassion. And as you say, like, GPs are often the people who are there after this has all happened, dealing with women who've had these experiences.
Mhm.
Do you think primary care and general practice is as equipped to support these women?
Yes and no. I think GPs in general are exceptional at managing mental health conditions, bereavement, psychological safety. The majority of GPs that I know are incredibly compassionate. We'll always hear stories about women who've had bad experience or who feel fobbed off by their GP. That's the saying that always comes through, is that my GP fobbed me off. And to those women, we need to really listen and figure out what went wrong there, and then provide some extra training for those clinicians providing that care. I think on the whole, GP is a brilliant place to look after these women. We've seen them hopefully for, throughout the course of their lives in a lot of cases, although the continuity of care aspect is probably another podcast in itself. We're aware of the more social support setup, their family setup, and we can provide those more regular touch points following their discharge from maternity services. But equally, I don't think that it can be purely GP led. So we know that maternity service debrief, for example, is so critical to helping women to make sense of their experience, to be able to start to heal from that. And we also know that GPs don't have enough time to provide that psychological support. So actually specific psychological support for women postnatally is critical to providing that care and continuity and just that extra time that they need in order to start to make sense of their experience.
Is there anything general practice can do to specifically identify and then support patients who've had a traumatic birth when they come to the surgery? Or is it just something that you'd pick up during that 6 to 8 week check?
I don't think it's something that's just picked up, which I think is a big part of the problem. I think often women assume that their experience was normal.
Right.
And if they can't deal with it, then it must be their fault. And obviously, I'm kind of speaking from personal experience there, I'm sure. And I'm sure that there are lots of women who may recognize immediately that their experience was more traumatic than they anticipated. We did some work with an organization called Make Birth Better, and they are set up to tackle birth trauma, to provide training for clinicians and to provide resources for patients as well. And they worked with Professor Susan Ayres to develop a trauma screening question, which is brilliant. It's 5 questions, and the first question is essentially asking, did you find any part of your birth experience traumatic? Which is very much a yes no question. And then the subsequent 4 questions are all about any symptoms of post traumatic stress disorder. It's such a quick questionnaire, just a screening questionnaire. It really would help to flag those women who've had a traumatic experience and then start to think, maybe we should bring you back to explore this in a bit more detail. Do we need to arrange a debrief with the hospital? Is there anything else that we need to do here? For some women, the answer will be no, and they're happy to try and manage it themselves. But for some women, we really need to keep a closer eye on them, particularly in the context of knowing that maternal mental health issues post pregnancy are one of the leading causes of maternal death. So we need to be far better at recognizing that earlier and providing adequate support for women.
Does there need to be changes in the handover from maternity units to general practice? So GPs are kind of, it's already flagged almost straight away that the mother's had a difficult birth.
That's a tricky question. I guess my question in response would be, who's deciding that that birth was traumatic?
Yes.
I know women who've had what I would perceive to be a very straightforward home birth, and there was no issue at all. And medically, it's gone very, very well. But maybe there was one tiny thing that was said that made their experience very traumatic.
Yeah.
And then I've spoken to women who've had an emergency C-section under general anaesthetic and what I would perceive to be a very traumatic experience. And they've said, no, it was absolutely fine. I was very well looked after. They told me everything that was going on. Baby was fine. And so I think it's really difficult to label people's experiences as traumatic or not, because it's very, very subjective. But I do think that we can get better at the way that we communicate information between maternity services and postnatal care. So making it very clear on the discharge summary what specific things need to be coded in the notes so that when somebody then goes back later, it will come up or it will pop up that so and so had gestational diabetes or they had gestational hypertension. And actually, we need to be looking at that in a bit more detail.
Your organisation that you're the co-chair of, you're very focused on education for GPs as well. I mean, do you think GPs currently get enough education on perinatal care?
I do not. If I think about my own medical training, and this is back to medical student days, we learned the stages of fetal development and how to differentiate the baby blues from postnatal depression. And that was pretty much my teaching on perinatal care and contraception, of course. Um, I don't think that we dedicate enough time to women's health in medical student teaching. I don't think that GPs themselves get adequate training. Doing an obs and gynae rotation, for example, is not a fundamental requirement of GP training. So if you do not rotate through obs and gynae and then end up in primary care as a GP who's seeing an enormous number of women, how are you going to have the confidence to A, examine women, B, know what's normal and what's not, and C, just be able to have those very nuanced conversations about any aspect of women's health. And it's probably not going to go down very well, but I have always said that I feel GP training should actually be longer than it is. I don't think 3 years is adequate to give GPs enough knowledge to really start as an independent GP to be able to treat every single person, every single condition, and know so much about every single organ of the body. So, unpopular opinion, but I do think that we ought to be extending maybe by 1 more year for GP training just to give people access to, especially women's health and obs and gynae, but all of the other specialties that we need to be able to provide really holistic care.
And so, what sort of education does your organisation provide for GPs? What kind of things can people come and learn about if they want to come along?
So we provide education in a variety of different ways. So I would say, firstly, go and have a look at the website. There's a really great resources page. There's loads of different things spanning over the years that GPCPC has been up and running. We also run some educational webinars, which are a bit ad hoc at the moment, but we try and do at least 2 to 3 a year. So we've had one on health inequalities, gestational diabetes, of course. We've done some on perinatal mental health, and we have one about Dr. Divya's quality improvement work in access to postnatal care. So those will always become available on our website to keep an eye on. And then we also do virtual coffee informal drop-ins for people to just come along. We try and do one every couple of months, and they can just drop in, have a chat if there's anything that they're not quite sure about, or if they wanted to give us some news or tell us about any positive things that are happening in their perinatal care space. And we just use that as a bit more of an informal get together.
You mentioned gestational diabetes there, and I mentioned at the start that you're also an academic GP and very involved in research around women's health. And one of your interests is gestational diabetes. How did you get interested in that specific aspect of maternal care?
So I did academic GP training. And as part of the academic GP training, you are encouraged to do some kind of research project. So, in my very enthusiastic and somewhat naive state, I started talking to people to find out if there were any projects I could get involved with, and met a very lovely and clever endocrinologist at MFT, Dr. Basil Issa, who said, actually, there's this really interesting research project I'd like to do. And I thought, great, let's do it. And then somehow fell into helping to run an entire clinical trial, which was a bit of a baptism of fire, really, but it was an incredible learning experience, an incredible opportunity for me. And we looked at intermittent fasting and gestational diabetes. So trying to determine whether an intermittent fasting approach might be feasible as a way to help women control their blood sugars in pregnancy. And then off the back of that, I became a bit more interested in health inequalities, particularly in looking at gestational diabetes in South Asian women. So, South Asian women are far more likely to be affected by gestational diabetes than white women. And so this last year, I've been doing a lot of work with some local charities in improving education around gestational diabetes and trying to reduce the long-term progression to type 2 diabetes, because we know that around 50% of these women tend to go on to develop type 2 diabetes within 5 years. And so anything that we can do within that interpregnancy period to try and prevent that progression to type 2 diabetes is so important.
Like you say there, gestational diabetes means that people have a much higher risk of going on to develop type 2 diabetes. So what steps should a GP's primary care teams be taking to sort of modify those risk factors once the patient's been discharged from maternity services?
Well, I am super excited because NHS England has just announced that gestational diabetes is now being incorporated into QOF. So that is really nice. And it feels like such a teeny tiny step, but it's actually so important because it now means that these women are truly recognized at being at a higher risk of type 2 diabetes. And it's taken so many years to try and get it incorporated within QOF and so many different organizations and people. So the fact that it is now formally recognised within QOF means that these women will hopefully be more proactively recalled back to have their annual HbA1c to screen for diabetes. So that is excellent news. That's number one, is making sure that these women do actually come back for their HbA1c testing and screen for diabetes. But I feel quite strongly that we shouldn't just be screening for diabetes. I think we should be checking blood pressure and lipids as well. So we need to be looking at this in the context of the wider cardiometabolic syndrome. So we know that diabetes isn't just diabetes, but it's reflective of overall health, of which there are other issues. So higher blood pressure, insulin resistance, overweight and obesity, and all of those things that come alongside it, dyslipidemia, of course, all these different problems. So I think we need to take a more holistic approach. And as part of that, one of the key things that primary care can do when they receive a discharge summary is code adequately. So coding is a real problem in primary care. And if we don't have gestational diabetes coded as a problem, then these women won't be recalled. It's all about making sure that the notes are up to date, they're coded adequately, and then hopefully these women should be recalled for their type 2 diabetes screening annually. There's a push at the moment to try and differentiate different types of diabetes, and we know that a lot of women who are diagnosed with gestational diabetes might actually have MODY, or maturity onset diabetes of the young. So it's definitely something that we need to consider more within that postnatal period in women with a history of gestational diabetes. If they don't fit a specific phenotype, if they haven't had increasing insulin requirements, for example, and there's a really strong history of diabetes in the family that doesn't quite fit the typical type 1, type 2 boxes, to always consider MODY. And if you have any suspicion that it could be, to then refer those women for genetic testing, because that has a knock-on impact on their future children and their children, because we know it's a genetic variant of diabetes. And it is quite rare, but it's certainly something that in Manchester we're doing a lot of work to try and improve detection of.
Before we finish, I just want to know if there's one practical takeaway or a single change you'd love every GP or practice manager listening to this today to implement in their surgery when it comes to perinatal care. What would it be?
Can I have a few? One would absolutely be coding, because we know that coding is there for safety reasons, recall reasons, audit reasons. So coding is really important and it's easily implementable. Two is making sure that we do offer standalone postnatal appointments for women. To not provide those appointments is doing women a disservice and is actually going against our contractual obligations as GPs. So making sure that we're providing that standalone postnatal appointment for women. And finally, I think that we really need to move towards looking at perinatal care across the life course rather than looking at pregnancy in isolation, because we know that pregnancy and pregnancy-related health conditions do not only affect women during the perinatal period specifically, but they are a window into understanding their overall health over the course of their life. And I think we need to move towards providing a more holistic life course approach to women's health.
It's been great to talk to you today, Liz. Thank you so much for coming on the podcast.
Thank you so much for having me.
Well, that's it for this week. Thanks so much for listening, and thanks again to Liz for speaking to me this week. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.